Hello students, today we will look into the clinical and nutritional aspects of hyperlipidemia. As the name suggests, hyperlipidemia means elevated levels of lipid fractions in blood. First, let us look at what hyperlipidemia really means. It is a condition in which blood plasma contains high levels of lipids and or lipoproteins. This can be primary due to genetic factors or secondary, which may be due to underlying conditions such as diabetes, hypothyroidism, nephrotic syndrome, alcohol, as well as the dietary intake. Finally, it may also occur without any specific cause, which is known as idiopathic. The daily consumption of food provides part of the required cholesterol, and 20 to 25% is manufactured by the liver. The remainder is synthesized by the intestine, adrenal glands, reproductive organs, and other tissues. Cholesterol is found in abundance in egg yolk, various oils, fats, nerve tissues of the spinal cord, brain, and kidneys. Excess carbohydrates also get converted into fats and cholesterol. The foods which can raise the blood cholesterol levels are the foods from animal products, meat, brain, kidneys or their products, excess consumption of simple sugars, lavish lunch and dinners, food habits and choices, and input versus output, that is predominantly the lack of exercise. This is a pictorial representations of the foods which are very rich in fat and sugars. Elevated blood levels are associated with cardiovascular diseases. Low density lipoprotein cholesterol, LDL-C, gets deposited within the arterial wall of large and medium-sized arteries as atherosclerotic plaques. These cause obstruction of arteries and, depending on the extent of obstruction, may contribute to hypertension, that is, reduction in the amount of oxygenated blood that reaches the heart, and in increasing the risk of coronary heart disease, abbreviated as CHD, myocardial infarction, and cerebral arterial diseases. Let us look at the transport of lipids in blood. After absorption from the alimentary canal, nutrients must be carried in the blood either to storage depots or to the muscles and other tissues where they are utilized for different functions. Lipids are insoluble in water and are carried in different ways as chylomicrons, secondary particles, low and high density lipoproteins, and as free fatty acids. In all of these forms, the lipid is attached to proteins. These lipoproteins are very different both in chemical structure and their physiological function. Let us look at these. The first one, the chylomicrons. Chylomicrons are the chief vehicle for the carriage of lipids from the alimentary canal to the liver. Chemically, they are triglycerides and contain 2% proteins and very small amounts of phospholipids. The second category is the very low density lipoproteins, the VLDL. This cholesterol is produced by the liver and is made up of 50 to 65% triglycerides and 20 to 30% cholesterol. It is responsible for transporting triglycerides synthesized in the liver to adipose and the muscular tissue. What remains of VLDL is broken down to LDL, the low density lipoproteins. LDL, which is commonly referred to as the bad cholesterol, consists of a predominantly cholesterol inner core, forms as a result of breakdown of metabolites of VLDL. It is made up of 51 to 58% cholesterol, 4 to 8% triglycerides, and it makes up about 60 to 75% of all the plasma cholesterol. Its main function is to deliver cholesterol from the liver to the cells. If large quantities of LDL are carried and no new LDL receptors are formed, the LDL absorption diminishes and a harmful buildup of LDL will take place, which increases the risk of CHD. High density lipoprotein HDL, commonly known as the good cholesterol, tends to prevent arterial disease from occurring as it takes cholesterol away from the cells and back to the liver, sometimes also called as the scavenger lipoprotein. Once in the liver, it may break down or be excreted from the body as waste. It is the smallest and most dense of lipoproteins. High density lipoprotein constitutes 18 to 25% cholesterol, 2 to 7% triglyceride. It contributes approximately 20 to 30% of the total cholesterol in the bloodstream. The main function of HDL is to transport cholesterol from the body tissue to the liver, where it is broken down and excreted in the bile. This accumulation of cholesterol is prevented. The amount of transported cholesterol is about 25% of the cholesterol in plasma. High HDL blood levels reduce the risk of incidence of coronary heart disease, unlike high LDL and VLDL blood levels. It has been shown that physical exercise tends to elevate HDL blood levels. If we look into the blood lipid profile, these are the levels that we have to be very careful about. Total cholesterol should be less than 200 milligrams per 100 ml. That is the desirable level. For LDL, it should be less than 100 milligrams. HDL should be more than 50 milligrams, and triglycerides less than 150 milligrams per 100 ml. When we look at the high risk total cholesterol, it will be more than 240. For LDL cholesterol, it is a high risk when it is beyond 160 milligrams per 100 ml. HDL cholesterol, if it is less than 35, and triglycerides more than 500 milligrams per 100 ml is a high risk. Now let us look into the clinical aspects of hyperlipidemia. Hyperlipidemia of genetic origin is different from the diet-induced elevations of blood lipids. The elevated levels of blood lipids in hyperlipidemia is due to defects in certain metabolic processes. Therefore, in addition to regulating diet, drugs may be required to control the blood lipids. In 1967, Fredrickson et al. Classified the hyperlipidemias into 5 types. Let us have a look at these 5 types of hyperlipidemias. Type 1. The elementary lipemia seen after a meal containing fat is not clear at the normal rate, and the chylomicrons persist in the blood on an ordinary diet. It's a rare type seen in childhood, often familial, and appears to be homozygous form of a rare autosomal mutant. Abdominal pain, pancreatitis can occur, and enlarged liver and spleen is also seen. Eruptive xanthomata, small yellow skin nodules on a faintly erythematous base, which appears when the plasma triglycerides are very high. Lipemia may be visible in the retinal veins. Plasma triglycerides are very high, and though cholesterol is moderately elevated, the triglycerides cholesterol ratio is almost about 10:1. Type 1 hyperlipidemia is not associated with diabetes and does not predispose to atherosclerosis. These are the lipemic retinalis as seen. In type 2 hyperlipidemia, it is again of 2 types, type 2A and type 2B. Type 2A, it is a dominant genetic disorder detected by blood examination at childhood and sometimes in the cord blood. Type 2B may be either genetic or acquired. Both types are secondary to diabetes, nephrotic syndrome, and hypothyroidism. The plasma cholesterol is usually 300 to 350 milligrams per 100 ml, and with increasing age, other clinical signs may be detected. Xanthomata is common, corneal arcus and xanthelasma of the eyelids is present. Both types are strongly associated with accelerated atherosclerosis, particularly of the coronary arteries. This is a corneal arcus. Type 3 hyperlipidemia, this is less common but not a rare disease. It is usually familial and transmitted as a recessive trait. Both cholesterol and triglycerides are moderately elevated in the plasma, appearing in approximately equal concentration. Overweight is common. Xanthomata appears as masses around the elbows or knees. The abnormal lipoprotein in type 3 appears to be an intermediate in the formation of VLDL to LDL. This is the xanthomata on the elbows and knees. Type 4 hyperlipidemia. Here the plasma triglycerides are above the upper normal limit. Plasma cholesterol is not above normal unless triglycerides are considered elevated, because VLDL contains about 5 times as much triglycerides as cholesterol. It is the most common hyperlipidemia in adult men and women, but it is not seen in children. It is associated with diabetes, alcoholism, nephrotic syndrome, pregnancy, use of contraceptives, and a change to a high carbohydrate diet, and with several other diseases and metabolic stress. In some cases, synthesis and release of VLDL from the liver is increased, or peripheral removal of VLDL appears to be inadequate. Type 5 hyperlipidemia. It is uncommon but not rare. It is a sum of types 1 and 4. There is an increase of VLDL and an accumulation of chylomicrons in the plasma. It occurs in patients with diabetic lipemia, with pancreatitis, in some alcoholics, in nephrotic syndrome, and some other diseases. Occasionally, it is familial, and type 4 hyperlipidemia may be present in other members of the family. Unlike in type 1, it does not occur in childhood. Now let us look into the causes of hyperlipidemia. Diabetes, hypertension, hypertriglyceridemia, which increases the LDL levels. Then gender, men have a greater chance of developing hyperlipidemia than women. Age, as a person becomes older, so does the chance for developing atherosclerosis and hyperlipidemia. Animal foods, high saturated fats, high intake of sugars and sweet increases the risk of hyperlipidemia. Sedentary lifestyle, it has been shown that non-vigorous physical activity tends to increase LDL and decrease the HDL blood levels. Body weight, overweight and obesity are associated with hyperlipidemia. Smoking causes cancer and cardiovascular diseases. It detrimentally affects the levels of HDL and LDL. Cigarette smoking decreases HDL level and parallel elevates the LDL levels. Alcoholic beverages. Persons who regularly consume large quantities of alcoholic beverages exhibit high amounts of LDL and low amounts of HDL levels. Cholesterol blood level is normally unaffected in people who do not drink or who drink in moderation. Now let us look at the risk of hyperlipidemias. The first one is atherosclerosis, or the hardening of the arteries. It is a common disorder and occurs when fat, cholesterol and calcium deposit in the arterial linings from the multiple plaques. A plaque normally consists of 3 components: atheroma, which is a fatty, soft, yellowish nodular mass located in the center of a larger plaque that consists of macrophages. It has a layer of cholesterol crystals and a calcified outer layer. Atherosclerosis is the leading cause of cardiovascular diseases. This is a representation of how the plaque forms from initial fatty streaks to a frank, large plaque. Second is the coronary artery disease, the CAD. Narrowing of the arteries that supply blood to the myocardium and results in limiting blood flow and insufficient amounts of oxygen to meet the needs of the heart. The narrowing may progress to the extent that the heart muscle would sustain damage due to the lack of blood supply. The third one is the myocardial infarction, the MI. It is a condition when blood and oxygen supplies are partially or completely blocked from flowing in one or more of the cardiac arteries, resulting in damage or the death of heart cells. The blockage is usually due to the formation of a clot in an artery. This condition is commonly known as a heart attack. The occlusion may be due to ruptured atherosclerotic plaque. If untreated for a period of time, the blockage can cause damage or death of the myocardium cells. The next one is angina pectoris. This condition is not a disease, but a symptom of an underlying heart condition. It is characterized by chest pain, discomfort, or a squeezing pressure even with minimal activity. The pain may also be felt in the shoulders, arms, neck and back. Angina occurs as a result of the reduction or a lack of blood supply to a part or the entire heart muscle, as well as impairment of the waist removal. It is usually due to CHD when partial or complete obstruction of the coronary arteries is present. The next one is stroke, or what is commonly called as the cerebrovascular accident, the CVA. It occurs when the blood circulation in part of the brain is blocked or diminished. When blood supply, which carries oxygen and glucose and the other nutrients, is disrupted, brain cells die and become dysfunctional. Usually the stroke occurs due to blockage of an artery by a blood clot or a piece of atherosclerotic plaque that breaks loose in a small vessel within the brain. Let us look into the nutritional aspects related to hyperlipidemia now. The principle of diet in hyperlipidemia condition is low calorie, low fat, particularly the low saturated fat content, low cholesterol, high in polyunsaturated fatty acids, the PUFA, with the N6 to N3 ratio being 4 to 10:1, low carbohydrate and a normal protein, mineral and vitamin diet. A high fiber diet is recommended. Total energy. Total calories should be restricted so as to reduce the weight to the expected normal for height, age and sex. Generally, 1000 to 1200 calorie diet is suitable for hyperlipidemia with patient with obesity. Fat. Restriction of fat no more than 20% of the total calorie consumed. It is not desirable to restrict all forms of fat, as severe restriction results in mental and physical depression. In the diet, the proportion of saturated to monounsaturated to polyunsaturated fat should be 5:6:4. PUFA, omega-6 fatty acids, linoleic acid lower both total cholesterol and LDL cholesterol levels. However, very high levels of linoleic acid also lower HDL cholesterol levels. Omega-3 PUFA lower LDL cholesterol and the total serum cholesterol levels, but they do not alter the HDL cholesterol levels. High intake of polyunsaturated fatty acids, PUFA, it causes increased esterification of cholesterol, makes it more readily utilizable. It decreases thrombosis. It decreases accumulation of cholesterol in blood serum and blood vessel levels. It decreases synthesis of VLDL precursors. It decreases production of LDL and triglycerides, and it also increases the clearance of LDL. MUFA, that is monounsaturated fatty acids. These are oleic acid and erucic acid. They are present in vegetable sources like olive oil, canola, almond oil and groundnut oil. They lower LDL without lowering HDL cholesterol. Large proportion of MUFA in diet may be conductive to thrombolysis and they could be anti-inflammatory. Then cholesterol. The cholesterol level in the diet should not exceed 300 milligrams. Liver itself synthesizes as much as 2 grams of cholesterol per day. The advantage of a vegetarian diet is it is low in calories, fat and cholesterol, has a high P to S ratio and has adequate fiber, which helps in binding and thereby increasing the excretion of cholesterol. Let us look at the desirable percentage of calories from different fats. The total fat should be less than 30% of the total calories. Saturated fat should provide 8 to 10% of the total calories. PUFA should provide 5 to 8, and the ratio of polyunsaturated to saturated fat 1 to 1.5:1 should be maintained. Then carbohydrates. As total calories are restricted, carbohydrate intake should be reduced. By reducing the sugar intake, even the serum triglyceride levels are decreased. Dietary fiber. High fiber diet reduces cholesterol, pectin present in apples and guavas, lower the level of serum cholesterol and enhance the excretion of fecal steroids. It has no effect on serum triglyceride and HDL cholesterol. Guar gum, which is extracted from cluster beans, and psyllium has hypocholesterolemic effect. Oat products contain high amount of beta glucans and also have hypocholesterolemic effect. Proteins and micronutrients. Normal allowances of proteins are recommended. Animal proteins are not suggested because they contain high amounts of saturated fats. Since total fat, animal fat, organ meats, eggs and seafoods are restricted, there is a possibility of vitamin A deficiency. Therefore, vitamin A supplementation may be required but under medical supervision. Sodium has to be restricted if there is hypertension. These are the foods which are encouraged to be taken: flax seeds, garlic, because they have hypocholesterolemic effect. So in conclusion, we can say that hyperlipidemia could be genetic due to diabetes, hypothyroidism, or even related to faulty food habits. They are subdivided into 5 categories, which can be genetic or identified in children or purely adult related. Type 4 is most common. Dietary modifications, inclusion of MUFA, PUFA and exercise are essential to maintain ideal lipid profile. Thank you.